Hello all. Thanks for joining today's CPAN-CME, the Management of Aggression in the Traumatized Child. We have Dr. Beverly Bryant who will be presenting here. We have just a couple more folks that are joining, and we'll give them about 1 more minute and we will get started. At the completion of today's CME, we will be sharing a QR code for you to complete your evaluation so you can obtain continuing education credits, CMEs from our institution. There'll be more information about how to obtain that at the end. Again, we are recording this session. We will post it on our YouTube page, and that will be available for future review if you'd like to look at that again or share it with others. All righty, I'm going to go ahead and stop sharing this screen just briefly. I do want to bring up just a moment and share a bit for those of you who are not familiar with the Child Psychiatry Access Network. We have some folks joining today who have not been fully made aware of our program yet. Let me bring that up just really quickly. So the Child Psychiatry Access Network was funded and initiated back in 2019, going live in 2020. The Child Psychiatry Access Network in Texas provides services and assistance to providers, PCPs, working with children and adolescents, serving all the way up to age 22. The services of the Child Psychiatry Access Network are provider to provider. This is not a patient-facing service, but a support and adjunct to the care that PCPs in Texas provide to their children and adolescents in their practice with child mental health and behavioral health issues. We provide that child and adolescent psychiatrist consultation. So direct psychiatry consultation prompt right over the phone between our child psychiatrists and the PCP. We make that very convenient and easy. If you're not familiar with CPAN, please do reach out to us and we would love to share more about our program. It's a simple toll-free call to what we call our hotline, and you can speak directly with our staff here. We are located in the Northeast Texas area. There are 12 hubs across the state who serve all 254 counties. We provide also care coordination and clinical support to assist with referrals and resources, safety planning, support with assessments, and crisis plannings as well. We will provide those referrals and resources that are validated. We will actually make those phone calls out to potential referral sources for you as a PCP and then send those options to you, either whatever's convenient for you, either through email, through fax, or we can send out those resources back over your cell phone. And as today you're seeing, we provide training and continuing education. Twice monthly, we provide continuing education from our hub, and there are also opportunities from our sister hubs as well across Texas. Also emails, newsletters, the newest information on child and adolescent mental health so that you can provide the excellent service in the area of behavioral health to your patients. Just to give you an idea, because of the lack of practicing child and adolescent psychiatrists in Texas, we here are providing in Texas assistance to serve you. It can take months, sometimes as much as 4 to 6 months to get into a child psychiatrist. So to have that adjunct to assist you in the care of your children and adolescents in your practice is what we're all about. We also provide a toolbox that we consider to be quite thorough in providing screening tools and other potential assessment tools for you to assist with diagnosis. And just a quick picture of our team here at the University of Texas Health Science Center in Tyler. 3 child psychiatrists, 2 therapists, and we're here for you. So more information is available by contacting CPAN. That is CPAN info at uthct.edu. cpaninfo@uthct.edu. So Dr. Bryant, I'm going to hand this over to you, and I'll let you introduce yourselves. What I will share is that Dr. Bryant is our chair of Department of Psychiatry and Behavioral Medicine here at UT Health Science Center in Tyler, and I'm going to have her share a little bit about her background. Dr. Bryant, it's all yours.
Thank you. Now, one thing I have to ask is a technical question. I can't see the slides on my screen, so I'm trying to figure out how to make that happen. Can you assist me with that? Can you guys see it now?
Nope, not yet. Would you like me to facilitate the slides? Would that be easier for you?
Well, at some point, yeah, I had it pulled up, and then when you came on, it went away. So I don't know what to tell you at the moment. So yeah, I don't know how to get back. Let me see if I can share my screen. Hey, let me try this.
Okay.
See if that's going to work. There we go.
There
Can
you
you
go.
guys see that?
Yes,
awesome.
ma'am.
Excellent. Very good. Well, listen, it's my delight to present to you management of aggression in the traumatized child today. I'm the chairman of the Department of Psychiatry and Behavioral Medicine at the University of Texas Health Science Center at Tyler. I have a background in working with traumatized kids, and I'm also the co-chair of the Child Maltreatment and Violence Committee for the American Academy of Child and Adolescent Psychiatry. And my talk today is the basis for a chapter that I helped to write in Psychiatric Clinics of North America, Child and Adolescent Psychiatric Clinics of North America, regarding dysregulation in children as a transdiagnostic symptom. So I'm going to talk today about aggression in traumatized kids, and hopefully I have a lot of slides. Hopefully I'll get through them, and we'll have a chance to talk together at the end. I don't have any disclosures. I'm not being supported by any industry in this case. All right, so we'll start right here. Our learning objectives for today are to understand a little bit about the neurobiological basis of the fight-or-flight response, evaluate the interplay of trauma-informed interventions and behavioral interventions in the management of aggression in children exposed to maltreatment, and understand the risk-benefit ratio of medications commonly used to treat aggressive behavior in traumatized children. So that's a very, those are lofty goals. We'll see how far we can get. Almost everyone is familiar with the ACEs study, Adverse Childhood Experiences. It occurred as a collaboration between Kaiser Permanente and the CDC in the late 90s. And they were looking at population attributable risk, which is the proportion of the incidence of a disease in a population due to exposure to a particular risk factor. And what I found was that exposure to one or more ACEs accounts for 54% of the PAR for depression, 67% for suicide attempts, and 64% for addiction to illicit drugs. Exposure to 6 or more is associated with a 20-year reduction in lifespan. So when you think about population health, these issues are really very important. Examples of ACEs. I'm not sure that I can zoom in on this at all, but there are things like, did you often feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect you? Did a parent or other adult in the household ever push, grab, or throw something at you? There are did a household member go to prison? You can see a lot of the children that we work with have several adverse childhood experiences. And how common are they? Well, you can see that children with 0% make up just a little bit over a third of our population. 2/3 of our population has been exposed to one or more adverse childhood events. So one of the questions that comes up a lot is whether someone's behavior is manipulative or is it trauma related. So if a kid is acting out, what's the cause? Or is it a little bit of both? And often it's both. Manipulative behaviors usually are associated with some secondary gain. They tend to be controlling of the adults around them, and they tend to respond to behavioral interventions. Trauma-related problems are usually associated with emotional dysregulation, the inability to process verbally, and we'll talk a little bit about that in terms of neurobiology very soon, and often are triggered by the environment. So part of understanding this is to know what exposure to maltreatment and neglect does to the brain. And this is very important because not everybody meets criteria for post-traumatic stress disorder, but exposure to child maltreatment and neglect at certain critical points of development results in changes in brain structure and function. So I would refer you to Martin Teicher, who wrote an article in Nature Reviews in 2016 describing the neurobiological effects of exposure to maltreatment and neglect in childhood. He noted that even in individuals who do not have manifestations of PTSD, there are significant changes in the brain, and cumulative evidence supports the idea that those exposed to maltreatment and neglect in childhood rely more on unconscious and automatic responses to threat. Very important as we talk about the circuitry here, you'll see why that may be the case. Before we do that, I'm going to talk to you about a case, a real case, that is also highlighted in the chapter, and many of you have probably been in an experience similar to this one, but it's called The Trouble with Mark. So Mark is an 8-year-old white male brought into an outpatient clinic by his foster mom because he grabbed a knife and threatened another foster child in the home. He has a history of abuse, but no one really has the details. No one really knows what that was about. He's in his 5th foster home placement and his 3rd Child Protective Services worker. He's sent for a psychiatric evaluation to the ER, and he's admitted to the Children's Psychiatric Unit. And there he continues to be aggressive. He requires seclusion, PRN medication to control his behavior. And you are there making rounds, and the staff angrily approach and say, what are you going to do about this? What are you going to do about this behavior? And when you ask, gee, is there anything that triggers this explosive behavior? They say, whenever he doesn't get his way. So what do you do? How do you assess this situation? Keep this case in mind as we go along. There's a book called Why Zebras Don't Get Ulcers. It's an old book, but it's a great book. It talks about the fight or flight response. And the thing to remember about the fight or flight response is that it's very primitive and it's automatic. So when a zebra is at the water hole and a lion approaches, it has 2 choices. It can run from the zebra, it can run from the lion, or it can kick it in the head. It actually has maybe a 3rd choice, which is just to be lunch. Okay. But either way, the zebra has to use all of its bodily resources to survive. And so what happens when our fight or flight is activated? What happens is we have increased heart rate, rapid respiration, increased blood sugar, total evacuation of the bowel and bladder, diversion of blood flow away from internal organs toward the extremities and the brain. Think about that a minute. When I see adults with a lot of stress-related diseases, I'm not saying it's always true, but in the back of my mind, I'm wondering about whether or not there's been trauma. Heart disease, hypertension, asthma, diabetes, interstitial cystitis, irritable bowel syndrome, fibromyalgia, and migraine headaches. Very common in people who've been exposed to child maltreatment and violence. Not causative, necessarily, and not saying that everyone with these conditions has been exposed to trauma, but many people with trauma have these conditions. And remember that 20-year reduction in lifespan for people who had 6 or more ACEs. So what happens in the brain? Well, the zebra sees the lion, or we see the lion. The senses communicate that threat to the thalamus, and the thalamus has 2 ways of communicating to the rest of the brain. One is the short loop, and one is the long loop. The short loop bypasses the cortex, goes directly to the brainstem and the basolateral amygdala. Okay, it is immediate. It happens before you even have any conscious awareness that there's a lion at the water hole. The amygdala integrates that information, sends it to the body for action through the brainstem, and it's automatic. The long loop involves reciprocal circuits to the cortex and the hippocampus for affective modulation and contextual memory. So this is so that you can look at the clues around and be on the lookout for lions at the waterhole in the future. What is very interesting is that olfactory stimuli bypass the thalamus and go directly to the amygdala and the entorhinal cortex. And this may be why smells or scents are so powerful in trauma. And when you talk with folks about when they're triggered by a trauma, it could be alcohol in the breath, it could be the smell of smoke, it could be any number of scents that immediately trigger that trauma response. It's also fascinating to me that, when you've got a gut feeling about something, you sit there, God, I got a gut feeling about this. There's a reason. There are viscerosensory afferents that communicate through the nucleus of the solitary tract in the brainstem to the central nucleus of the amygdala and say threat. Motor, neuroendocrine, and autonomic pathways result in the expression of the fight or flight response. And again, this happens before the cortex has even processed that there's a threat. This is that automatic. So we're going to talk a little bit about the rooster and the owl. This is how I explain it to kids. The amygdala is like a rooster. It wakes everybody up and sets off the alarms. The owl is like the hippocampus. It's the wise old owl that kind of puts things into perspective. So the hippocampus has to put threat into context. And with chronic trauma, we know that the hippocampus is actually smaller. The volume is reduced. So back to Mark for a minute. What happens when he explodes? Well, how long does it last? What helps him, if anything, what helps him to calm down? Does it happen only when he doesn't get his way or at other times too? And a key question, is this fight or flight? So these are questions to ponder. This book, Trauma Systems Therapy for Teens and Adolescents, is a great book in looking at systems therapy for managing kids with complex trauma. And I highly recommend it. It's a brilliant book. And what I'm going to talk to you about is really based on that. A trauma system has 2 components. The child who experiences the survival in the moment state and a social environment that isn't able to help the child regulate. And what I love about this view is it takes into account the environment as well as the child. So you look at the social environmental stability. If it's stable, the child's caregiver or caregivers can adequately help the child regulate their emotion and protect the child against the triggers. If it's distressed, the child's caregiver cannot adequately help the child. And if it's threatening, then there's a clear and present danger. So what is emotional and behavioral regulation? Regulated means you're in control of both emotions and behavior. Emotional dysregulation obviously is emotion and behavior is both. So if we look at Mark, where is Mark and where's the unit? Is Mark regulated? Is he in emotional discontrol or behavioral discontrol or both? So where is Mark? Well, Mark's red. Mark's both. He's not in control emotionally or behaviorally. Where is the unit? Where are the nurses? Where are the folks that are trying to take care of Mark? They're distressed. They're angry. They're there. It's like, do something. They're not threatening, but they're distressed. So you have to take that into account when you think about interventions. So this is what I think is brilliant about this book. It's the grid, and it takes into account the child and the environment. So when you look at the interventions, safety focus is going to be there whenever the environment is threatening. Your focus will always be on safety. If the environment is distressed and the child is behaviorally dysregulated, your focus is on safety. But if the child is not behaviorally dysregulated and the environment is distressed or stable, you can start teaching that child regulation skills. Here's how you get back to green. And so what we used to do is we'd have groups, we'd identify how do you feel when you're red, yellow, or green? And when you're yellow, how do you get back to green? If you're red, how do you get to yellow? And our interventions are all designed around that. Beyond trauma means looking at other issues like attachment, trauma narratives, that kind of thing. That can only be done in a stable situation. So the 3 phases are safety focused, regulation focused, and beyond trauma. I will tell you as a clinician that these phases just do not follow neatly one after the other. People go back and forth. They, depending on what the triggers is, what the environment is, we will be maybe working here and go all the way back there. And that's why the trauma system is so valuable, because you can hopefully not reinvent the wheel every time there's a shift. So treatment phases, safety focused, you establish the safety of the child and the environment. It includes the trauma system, intensive home services, community-based work, treatment activities that focus on building the capacity of those around the child to help and protect. And regulation is teaching the child and child caregivers the skills that they need to regulate those emotional states when a threat is perceived. And that kind of treatment often occurs in an office or a clinic. And then beyond trauma, the social environment is stable, and treatments can look at trauma-focused cognitive behavioral therapy, trauma narratives, so forth. And it's really a time when the child and the family unit try to make meaning of what has happened to them. I'm hoping to get through all of these slides, so I'm going to kind of rush through these a little bit so that we have time for questions. The 4 R's: regulating, revving, re-experiencing, and reconstituting. When you're working with a child, you can see when they're revving, they're revving up, and then when they're re-experiencing, they're flooded. Now they're in the fight or flight completely. A common mistake is during reconstituting, the child try to get back grounded. That is often a time when people confuse the child's state with regulated. And that is not the time to give behavioral consequences. When the child is reconstituting is not the time to say, by the way, now you're not going on the outing, you've lost all your privileges, so on and so forth. That will take you right back to revving or re-experiencing. And again, safety focus is crucial. You have to get into a safe place before you can do anything else. So We want the family to have an emergency plan. And we want the family to recognize when the child's behaviors are green, yellow, or red, and have a plan for when we go to red and how to go move from one state to the next. All right. So I'm gonna go here. What are regulation focused techniques, cognitive techniques, understanding the antecedents, the behavior and the consequences? What is it that kind of set this off? Building a toolkit. What can the child do? What can others do? And honestly understanding too the neurobiology. The more that you activate the frontal part of your brain, the more control you get over the limbic system. So practicing this and making it conscious and working on it actually strengthens the hippocampus, which is what we want to do. So getting the caregivers to also understand this, one can make a poster of the skills, a poster of the feelings. We would have kids make posters of each state, so they could more easily identify, and caregivers could identify where they are. Beyond trauma, the mnemonic, strengthening cognitive skills, telling the story, the trauma narrative, reevaluating needs, orienting toward the future, nurturing parent-child relationships, and going forward. I will say for young children, one of the things that we really want to do, and I'm hoping we'll be able to do here in Tyler soon, is provide parent-child interaction training. It has an incredible evidence base, and it is one of the few evidence-based therapies that actually can also reduce future abuse by building that relationship with the child and the parent. It's real-time feedback for a parent working with their child. It can even be in their home to manage behaviors and to learn how to listen to their child and enjoy their interactions. So what about medication? Well, unfortunately, we don't have a pill that will fix this. If we did, I would have retired a long time ago. Symptoms such as emotional and behavioral dysregulation are very common in children exposed to maltreatment and violence. There are also difficulties with attention, anxiety, depression, and Brooks Keeshan, and this is highlighted in references, has written extensively about medication use for patients whose primary diagnosis is trauma. And what you have to realize is that there is no medication currently approved by the FDA to treat specific PTSD symptoms in children and adolescents. So every medication we use in this situation is off-label. And I guess that might be a disclosure that I was going to talk about some things that are off-label. But what's the reality? Many physicians are forced into using medication to treat trauma-related symptoms because the therapies, the evidence-based therapies, are not available. And unfortunately, a lot of times it results in the use of antipsychotic medications or polypharmacy. And evidence-based are the first line of treatment, and they're more effective than medication, but we don't always have access to them. So if you do have to use medication, one of the big target symptoms that can be helpful is sleep. Getting a child to sleep and getting the caregiver sleep can work wonders. The basic principles are start low, go slow. You could consider prazosin. There's some open label trials with prazosin and anecdotal evidence. For hyperarousal, one can consider clonidine, guanfacine, but you don't want to use multiple antihypertensive agents, so you don't want to use prazosin with guanfacine or clonidine. You want to monitor very closely for suicidal ideation. Treat any comorbid conditions, which can be difficult to parse out. Is this attention problem trauma, or is it ADHD? So that's one of the things that is a challenge in working with these kids. You need to avoid polypharmacy, benzodiazepines, and antipsychotics if possible. So back to Mark. Okay, what caused Mark? What happened to Mark? Well, Mark was told no, okay, by a favorite staff member. He wanted to go first, or he wanted something, and Mark, the favorite staff member, said no. So he flew. Well, is that because Mark's a brat? Is that because, what's the reason for that? Well, later, when Mark can process, what no means is that this individual, this favorite staff member, doesn't like him. They like other people more. And then that leads in the cognitive spiral to they don't care about him. They don't care about what he wants. He has to grab everything he can because he'll never get another chance, and he is going to be abandoned. So that cognitive spiral happens really quickly. So he starts going into the re-experiencing state. He's not responsive to reason, command, or cajoling. Okay, so we can't reason with him. What happens also when you're in that fight or flight state is that Broca's area shuts down. You honestly can't speak. You're speechless. So those higher levels are not functioning. Rewards and punishments are now mixed up with threat. Restraint, seclusion, and shots are re-traumatizing. And when Mark is reconstituting, he can't yet explain what happened. So when Mark is green, he can work on these cognitive and regulatory skills. Both caregivers, staff, and Mark need to identify the revving when we're revving and divert it if possible. Now, what did we do with Mark? Well, of course, we made the environment safe for him. We allowed him to finally calm down, and then we were able to process. But this is based on a relationship. We know that the strength of that relationship is what makes our interventions usually the most effective as parents, as caregivers. I had a patient that came in, and the parents said, I don't understand. He does all these things. He never does it with Grandpa. And so I'm thinking, well, I guess Grandpa must really be, quite the taskmaster. I said, well, what do you do with Grandpa? And they stopped and thought a minute and said, takes him fishing. Oh. So Grandpa takes him fishing. They have all sorts of interactions that are positive, that are not based on power struggle, not based on demand, and that's that way. When Grandpa says something, that child is invested in what Grandpa thinks and wants to please Grandpa. It's very, very important. So I'm talking about oxytocin, the love hormone, and this is a picture of my basset hound, Lady Gwen of Ears, we call her. She is highly loved and the source of much oxytocin in my family. My children come visit mainly Guinevere, not us. So just to let you know. But oxytocin is released between loving mothers and infants. People and dogs increase each other's oxytocin levels, and oxytocin release is protective. So processing traumatic stimuli while activating higher cortical functions at the same time helps extinguish automatic triggers. This is very important. Your limbic system is being triggered, your brain has been hijacked, and your plan, your only hope is to engage the brain. Try to get back to where you can engage those higher processes. So self-caring relationships are key, but they're not enough. So parents, foster parents, I've given them love, I adore them, I don't understand, I can't get anywhere. Knowledge is power. You have to understand what is happening in the brain. And you need a savings account of positive experiences built up for the caregiver and the child. That child needs to have the savings account of good experiences to know, wait a minute, it's not just a foregone conclusion that this is all going to go bad. That's one of the things that's helped with parent-child interaction training. And beware of Cartman's Triangle. This is an old concept, but it's concept. Many people who have complex PTSD relate to the world in one of these three roles. At any given time, their relationship with the other person is either as the other person is either rescuer, victim, or perpetrator. And they are either rescuer, victim, or perpetrator. So when you're dealing with your parents and they're telling you no, they are either going to be perpetrators, and you're the victim, or another parent, maybe in a divorce situation, is going to be the rescuer and you're the victim. When you are acting out and hitting people and biting people and engaging in violence, you become the perpetrator, right? So in all of these, in those roles, there's no winning. There's no winning. You have to elevate yourself out of this triangle. Start working again on those higher functions to say, no, we are not going to go back to just having to play one of these three roles. Very, very important. What did we do with Mark? Well, we cleared the area for safety. We tried some de-escalation techniques. We had worked beforehand on breathing, and he worked on that a little bit, and we provided reassurance. Finally helped him express what happened, and then we helped him define the problem and use some cognitive tools. When he was back to green, we made a safety agreement, helped him recognize things that will tend to set him off, and got him to challenge some of those thoughts. He's young, so that's sometimes difficult, but Mark did a good job with it. He really did. So references for you all. Dr. Keeshan has several articles on the use of medications. Dr. Teicher has a wonderful article on brain structure, function, and connectivity. We did a chapter in the series on emotional dysregulation. Gay Carlson, who's the president of the American Academy of Child and Adolescent Psychiatry, really was focused on the symptom of dysregulation. Many of you are probably familiar with the diagnosis of DMDD, which has caused lots of controversy in our profession. And emotional dysregulation and irritability are sometimes very difficult to place into one diagnosis. I will tell you that Dr. Carlson's working right now on getting an R code for irritability and dysregulation, so that when you have a child who has separation anxiety and they're having dysregulation, you can use an R code to explain the separation anxiety. If they have PTSD and they have dysregulation, you can use that R code. ADHD. So because those symptoms are not specific to one diagnosis, she's working very hard with the DSM-5R committee or TR committee to see if we can be more precise in our description, of kids. Because for a long time, every kid that became violent was seen as bipolar. And it became a huge problem within child psychiatry, and it remains a controversy to this day. And I do believe that there are children who are bipolar. I have no doubt about that. But trying to parse this out is always difficult. And in child psychiatry, we're catching something at one moment in time that is a longitudinal diagnosis. So this is a diagnosis that's going to declare itself over time. And we don't always know where we're intersecting with it. But that makes it more difficult in terms of management. So with that, I will stop and see if there are any questions, if you guys want to put them in the chat or even just break in and ask your question.
Thank you, Dr. Bryant. We appreciate this terrific presentation. And yes, please do, if you would like to ask your question verbally, go ahead and unmute yourself. But if you would like to place your question in the chat, we will certainly share those with Dr. Bryant to answer. So We'll give just a moment. This is terrific information, and I'm sure there are questions out there. And of course, as always, there are never dumb questions, so please do share.
I may have questions for you. How many of you have been, anybody could let me know, how many of you have been in this situation with a patient like Mark? How often that happened to you?
There is a hand raising option. Go ahead.
On the inpatient unit one time, we had a young man that would be pretty calm most of the time, but then just seemingly at random, we couldn't really identify the trigger. You know, he would do things like try to break out the window, you know, by lifting the bed and throwing it at the window. And I do remember the nurses coming to me, you know, just in a distraught phase, you know, saying, "Oh my goodness, you know, look what he's doing. What are you going to do?" You know, kind of a similar situation. And for us, you know, on the inpatient unit, with, you know, we try to have fast acting results. We did increase his antipsychotic medications.
Thank you, Dr. Watkins, for weighing in on that. Thank you so much.
Mm-hmm.
And again,
Yes,
and I'm assuming this is an adult patient, right? On an adult psychiatric unit, or is it a child?
He's an adult, but I mean like an 18-year-old adult.
Young.
So I guess I viewed him as a teenager, but by legal standards, yes, ma'am, he's an adult. He was an adult.
Okay. And do you know, was there any screening for exposure to childhood maltreatment and violence?
As I got to talk with the patient on more of a calm day and get more into his history, there was physical abuse from his father.
Mm-hmm. And depending on the age, there are tremendous. I have another talk on the neurobiology of trauma that will go into all sorts of details, because I'm a bit of a brain nerd. I love the brain, so you know, if I get to starting to talk about that, y'all will not get me to shut up. But people become less sensitive to when they're physically abused. They become less sensitive, and emotionally and verbally abused. They become less sensitive to oral stimuli, auditory stimuli, and even physical stimuli. They become desensitized to it, and so sometimes, and they also become less engaged in reward-seeking behavior. They don't expect rewards, so that's one reason why giving rewards and punishments to kids with trauma or adults with trauma may backfire a bit. And you guys may have run into kids who seem to, what I call, throw themselves away. They don't trust their environment. They don't trust that they're going to have a family, and they honestly just act out to the point where they throw themselves away. I've got a couple of things in the chat, and Dr. Johnson and Dr. Zantus, thank you so much. Saying that you guys have found yourselves in the situation with Mark often. Dr. Zantus, openness. Every fourth child or adolescent outpatient, if I had to guess. Dr. Johnson asked, can I speak to the underdiagnosis of trauma in children and adolescents? And there's some comments here. Abuse begets abuse. And that's very, very true. Intergenerational trauma can be a huge, huge problem. And if we go back to biology for a minute, it's even clear that there are changes, epigenetic changes in intergenerational trauma in terms of stress response. That's amazing. That's just a game changer. So I will ask Dr. Johnson to comment on the underdiagnosis of trauma in children and adolescents, and what you feel, Dr. Johnson, since you are one of our excellent CPAN providers with Dr. Kerr, Dr. Blood. What do you guys see as the reason for that?
Well, I think, well, first of all, after a great ACAP conference this past week, well, couple of weeks, I had noticed that there was a lot of talks and a lot of discussion regarding trauma and the underdiagnosis, misdiagnosis of trauma in children and adolescents, and how they are, you know, the main issue is that it's not being assessed. And so therefore, obviously, if it's not being assessed, it's being missed. And so those symptoms that we see, those externalizing behaviors, the disruptive behaviors are getting diagnosed more so as, you know, ADHD or, you know, oppositional defiant disorder, and sometimes even conduct disorder, especially when we're thinking about forensic populations. Of course, as you know, Dr. Bryant is one of my passions. And so and then what that causes is we end up not treating or not doing anything about the trauma, and then patients come into the office to see us and they expect that we will fix whatever issue it is with a pill. And, you know, that is just like you said in your talk, there is no pill that is going to fix this. We have to do therapeutic interventions, which take time to become effective. So it's like, yeah, you can use these medicines in the interim to kind of help. I use the term dampen down the symptoms, but the symptoms are not going to go away with the medications alone, and we have to do the therapy. And I know a lot of times that's frustrating to the parents when we have to say that. And I know it's probably frustrating when we have CPAN providers contact us and, you know, we have to say, you know, this sounds like this is trauma related, and, you know, we can try medicines, but that's not the issue. The issue is, you know, this other thing. And the CPAN provider, primary care provider, is like, well, what can we do now? You know, they want to do something that can fix now. And it's like, I don't have that. There's nothing like that exists. So unfortunately, you know, it just takes a lot of education to providers to understand that, and then, you know, be able to have those conversations with the families about the expectations for medications and what we can do, and why therapy is important. Because I know a lot of families too, you know, don't see the importance of therapy, and we have to stress that to them as well.
Thank you so much, Dr. Johnson, for that. That is such a great summary of what we deal with every day. And one of the things I try to help parents understand, because part of TFCBT is actually teaching them about what happens when there's a trauma trigger or a trauma reminder. And I try to teach them that therapy changes the brain. It changes the connectivity of the brain. It changes the way it works. It's like doing, I call them hippocampal push-ups. We're going to do some hippocampal push-ups. We're going to practice. It helps them understand that it isn't just talking about it. We're really using skills. We're really enhancing strengths in the brain. And I know Dr. Kerr has her hand up, and Dr. Maduri says that he hears from PCPs that it's very difficult to get their pediatric patients an appointment with child psychiatrists, general psychiatrists, therapists. Other than CPAN, what is being done? Well, I can tell you I'm working very hard to open a child clinic, another child clinic. We have wonderful providers here, Dr. Scardina, Dr. Zantus, lots of good child psychiatry folks here, Dr. Udema. But I'm hoping to open another clinic, and I'm hoping that we will have evidence-based trauma therapies available. Lots and lots and lots of barriers to that in terms of just the systems issues that we face. But I am doggedly determined, and so we are working very hard to get that clinic open, and I'm hoping we will then be able to provide some evidence-based treatment like PCIT and DBT, parent management training, and obviously TFCBT. And Dr. Kerr, your hand was up?
Yeah, I was just going to add on to what Dr. Johnson was saying about the underdiagnosis of trauma. One of the things that I have noticed is sometimes kids who maybe were adopted really young, families don't always understand that there's still trauma that happened, you know, during pregnancy or even in the short period of time before they got to family. So it's sometimes an education and kind of understanding that we are learning more and more how much impact even just the first couple months of life have on how we regulate emotions and responses to things. So that's another thing I think is hard to explain to families who are doing, you know, a fantastic job, but are dealing with past things.
Amen. Amen. The earlier it happens, the more the more impact it has usually. And the Teicher article really takes that down to specific time periods in terms of, you know, synapse development within the brain, functional connectivity networks. Depending on when that trauma occurs, it derails and hijacks brain development. And so it's not the foster parent's fault. It's not the child's fault. One of the hardest parts about trauma for people is understanding why the past is present in trauma. Because so many of my patients, as they've gotten older and they can speak to this, will say, everybody says that happened a long time ago. For God's sakes, get over it. Get over it. Well, you can't get over it if your amygdala constantly putting out the alarm saying, we're about to die. Okay, we're about to die. I want everybody to know here in the brain and the body, we're about to die. Okay, you can't focus on things. You can't put things into words. You can't, you know, adhere to behavioral plans. So until you get that and understand what's going on and help them gain some sort of control over it, which takes time, and the family knows, it's really, you know, you just tend to throw a lot of medications, a lot of therapies at things, and then they really don't work. But we do have evidence-based treatment for treatment of trauma, and we need to make sure that it's made available. Thank you, Dr. Kerr, so much. And yes, Dr. Young, Laura Young said we have a new child and adolescent psychiatry fellowship that's about to launch. And Dr. Watkins is one of our fellows. And I'm not sure if Dr. Carr is on here. She's another one of our great fellows that we're excited about. I see there's a hand raised, but I can't tell whose hand it is. So do you want to just hop in and ask your question?
Yeah. Hi, this is Dr. Chaudhry. Hi, Dr. Bryant. Thank you for the lecture. I was wondering, you know, what kind of caught my eye was that you were talking about, you know, therapy increasing neuroplasticity and altering brain pathways. And, you know, we don't have any medication treatment, but I was wondering how TMS, you know, because one of the bases of TMS is to increase and reactivate neuronal pathways. And if, you know anything about research into utilizing TMS in trauma-related, like trauma.
That is a great question. A great question. I'm not aware of any studies with TMS. Are you?
I think there's some in regards to, I did read something about actually that TMS is not as effective in childhood patients who have been impacted by childhood trauma. But I actually don't know much about it, so I was kind of wondering if anyone does.
It's a great question. I mean, it's such a great question, you know. Now, it would make sense to me that it might not be as effective in children. You know, if you have depressed children and then you have children who've been exposed to child maltreatment and violence, it would make sense to me that those children would be more treatment refractory. Okay, but I don't know that that means that there would be no hope for it to ever help. I think it's a fascinating question, something that should be looked into. Absolutely, great question. And TMS is hard to access as well. I mean, it's hard to get it paid for, and it's hard to find people who do it. So that's another one of our challenges with it. Any other questions? Laura has put some information in the chat about how to access this, I guess on the YouTube channel, and I will give you my email, which is all lowercase, beverly.bryant@uthct.edu. So if any of you have questions about trauma, or you have ideas or thoughts, please share them with me. It's something I absolutely it's what I've kind of devoted my academic career to, and it's unfortunately so pervasive that I think that it's something that we all have to learn more about. And Laura, did you have any parting comments in the last 4 minutes?
I just want to, let me try that again. Thank you, Dr. Bryant, for the opportunity to pick your brain on with these questions, to have you share your expertise with us here through the CPAN program, and the support that you provide our program here locally and at the state level, and your willingness to educate in the busy role that you have is very much appreciated, and the positive responses that we've had so far share that as well. I do want to say to those that are in attendance, if you are a Texas PCP and you are not already registered with CPAN, please do reach out to CPAN. I have put information in the chat about the program. If you're in the Northeast region, you would be served by the 3 psychiatrists, Dr. Johnson, Dr. Kerr, and Dr. Blood, as well as our 2 therapists, Elizabeth Hooker and Wiley Martin. If you are outside of the Northeast region, there are 11 other hubs that serve regionally. That way you have regional staff serving regional PCPs. The services for CPAN are at no cost. These are fully funded by the state of Texas. Texas cares about children's mental health, and they know that there is a need. So initiatives such as the CPAN program, the Child Psychiatry Access Network, the TCHAT program, which is providing counseling in the schools, workforce enhancement, fellowship, research. There is all kind of work being done and funded by the state of Texas. You have a state that cares about children's mental health, and they're trying to do something about it. We would love to serve you through the Texas Child Psychiatry Access Network. Simple program, simple single phone call. Let us be there to be your partner. We know it takes time to get in. To get you those children that with mental health needs in to see a child psychiatrist. There are just not enough in the communities. So if you will allow us to serve you, we would appreciate that. We're here 8 to 5 Monday through Friday. We have lines that are secure that you can leave a message and we will call you back. We try to make it easy, simple, and timely for you. Customer service is important to us, and I think you'll find once you try us, you'll like us. So, Dr. Bryant, that's all I have today. Do you have anything for final parting words?
No, just thank you so much, Laura, and to the CPAN team for what you do, and the TCHAT team for what you do. You're really making a difference for children, and we hope that as we have more child and adolescent psychiatrists trained in this area, we're going to have more services. And we really value those programs and what the state is doing to try to help children across Texas. So thank you to Dr. Kerr, Dr. Blood, Dr. Johnson, and our therapists who do such an amazing job. So thanks, guys.
Thank you, Dr. Bryant. You all have a wonderful day. I'm going to put up the QR code again for those of you who did miss it. Please complete your continuing education evaluation and our CME department of terrific staff. Meredith and Stephanie will get y'all squared away. Have a great day, and we hope to see you at our next continuing education, which will be in 2 weeks. If you have questions about obtaining that information, please do reach out. We'll get it for you. Take care and have a good one.